Hello everyone. Welcome to this webinar on pulmonary arterial hypertension. I am Dr. Lalitha, Assistant Professor from the Department of Cardiology. Me is Dr. Param Jyothi, Associate Professor and HOD from the Department of Pulmonology, NIMS, Hyderabad.
Hello.
Welcome to this webinar on pulmonary arterial hypertension, which is second in the series of the PAH webinars being conducted by WINCARS Association. WINCARS has taken the initiative to dedicate the entire month of May on behalf of World PAH Day, which is being celebrated on May 5th, in favor of pulmonary arterial hypertension. The aim is to conduct webinars to educate and update all physicians who deal with PAH. The first webinar has concentrated on the diagnosis as well as the classification of pulmonary artery hypertension. So, in this present episode, we are going to discuss about the diagnosis of pulmonary hypertension, and Dr. Param Jyothi will give us his opinion and updates regarding the management and treatment of pulmonary hypertension in COPD. For all those who have joined us for the first time, this is to recollect that pulmonary hypertension is a hemodynamic and pathophysiological condition defined as an increase in the mean pulmonary artery pressure of more than 25 mm of Hg at rest, as assessed by right heart cath. PAH is a specific subset of pulmonary hypertension patients who are characterized by the presence of precapillary pulmonary hypertension, that is, a pulmonary wedge pressure less than 15 mm of Hg and an elevated PVR of more than 3 Wood units, in the absence of other causes such as the lung, the CTEPA, or other rare diseases. PAH is classified as the Group 1 in the WHO classification. The PH in COPD belongs to the Group 3, that is, the PH associated with lung diseases and or hypoxemia. COPD is the most common lung disease associated with PH. So what are the other lung parenchymal diseases which can cause pulmonary hypertension?
The other lung conditions that are grouped in Group 3 pulmonary hypertension are interstitial lung diseases, patients with combined pulmonary fibrosis and emphysema, patients who have chronic alveolar hypoventilation, that is, those who have, say, severe kyphoscoliosis, or patients who have thoracic sarcoidosis, or certain rare conditions like Langerhans histiocytosis or lymphangioleiomyomatosis are some of the conditions that are grouped in this.
Based on the latest Dana Point Classification 2009, PH due to underlying parenchymal diseases such as COPD and ILD remain in Group 3. Other diseases with multisystemic and pulmonary manifestations such as connective tissue disorders and sarcoidosis have been categorized separately. What is the prevalence of pulmonary hypertension in cases of COPD? Is the severity of COPD and the severity of PAH related?
The prevalence is highly variable. It varies from 20 to 90%. It all depends on the definition that is used, whether the mean pulmonary arterial pressure is 20, taken as 20, or the mean pulmonary arterial pressure is taken as 25, or whether the severity of the COPD is considered based on FEV1 values, or the methodology that is used to measure the pulmonary arterial pressure, whether it is transthoracic echo versus the right heart catheterization. By and large, mild to moderate pulmonary arterial hypertension is more common in COPD patients. However, there could be a small subset of COPD patients with severe PH or severe pulmonary hypertension with mean pulmonary arterial pressure of more than 35 to 45 millimeters, which is again rare. But in such patients, we should always rule out left heart disease or obstructive sleep apnea or pulmonary embolism in this group of patients.
This is the data of patients with pulmonary disease with PAH from our institute. It's a data of 20 patients, of which smoking is seen to be the most common risk factor, seen in 85% of the patients. There's a male predominance. Coming to the underlying etiology, obstructive sleep apnea was common, seen in 10% of the patient. Isolated COPD was seen in 3. COPD with obstructive sleep apnea was seen in 3 patients. Pulmonary fibrosis and bronchiectasis with OSA was seen in 2 patients. 65% of the patients had moderate PAH. Severe PAH was seen in 35% of the patient. This study highlights the fact that severe PAH was seen only in patients with pulmonary fibrosis or an overlap syndrome, that is COPD with OSA or bronchiectasis with OSA. And as you said, in cases of isolated COPD, it is always moderate PAH, never a severe PAH. Pulmonary artery hypertension is a lethal disease. It is often diagnosed in the advanced stages because of non-specific nature of its early symptoms and signs. Hence, a high clinical index of suspicion should be present. The initial symptoms could be related to inability to increase the cardiac output during exercise, that is, exertional dyspnea, lethargy, or fatigue. As PH progresses and RV hypertrophy occurs, there might be exertional angina, syncope, and as failure develops, there might be peripheral edema, anorexia, and abdominal pain due to hepatic congestion. Uncommonly, we see cough, hemoptysis, and hoarseness in isolated pulmonary arterial hypertension. Coming to the physical examination, there is a raised JVP, ascites, peripheral edema, and hepatomegaly on abdominal palpation. On cardiovascular examination, there is a left parasternal lift and loud P2 and RV third heart zone, pansystolic murmur of TR, and diastolic murmur of PR. Some clues on the clinical examination can suggest the etiology underlying the PH, such as presence of telangiectasia, distal ulceration, which can suggest scleroderma, presence of spider nevus, testicular atrophy, palmar erythema, which can suggest a liver disease, clubbing, which is seen in cyanotic heart disease, or interstitial lung or liver disease. Sir, the clinical symptoms and signs in a patient with respiratory disease are quite non-specific because these signs may be masked because of the hyperinflated lung fields. The second thing, these can be seen in a patient of respiratory disease even in the absence of any right heart involvement. Then how do you suspect the presence of pulmonary hypertension in a patient of COPD?
A patient with a stable obstructive, spirometrically, if the patient has got a stable obstruction, then with the breathlessness or is disproportionate to the obstructive defect, and it has got a severe hypoxemia or hypocarbia, or patient has very low diffusing capacity, in such patients we would have to rule out pulmonary hypertension in COPD patients.
I would like to highlight the point that a very low diffusing capacity, a low SpO2 at rest, which further decreases on exercise, will suggest a pulmonary hypertension in COPD. All patients of pulmonary hypertension need to undergo extensive diagnostic testing, and the purpose is to confirm the presence of pulmonary hypertension and to identify the underlying cause. Of all the tests, the primary screening is the echocardiogram, and the right heart cath is the gold standard for confirmation of the diagnosis. The ECG is not diagnostic of pulmonary hypertension, but the changes can suggest pulmonary hypertension, such as a P-pulmonary, presence of RV strain or RV hypertrophy. Of the two, the RV strain is more sensitive, whereas the RV hypertrophy is more specific as a screening tool for PAH. In advanced diseases, there could be a prolongation of the QTC, wherein we differentiate it from ischemic changes. In advanced diseases, there can be supraventricular arrhythmias such as flutter and fibrillation. However, ventricular arrhythmias are rare. Note the point that an ECG, a normal ECG, does not rule out the presence of PAH. At the same time, abnormal ECG is more common as the PH severity increases. Coming to the chest radiograph, this is abnormal in more than 90% of the patients. There is a central pulmonary artery dilatation with peripheral pluming. There will be RV enlargement and RA enlargement. The chest X-ray can also help in the differential diagnosis by showing either the lung signs or a pulmonary venous congestion. It also helps in distinguishing an arterial and venous hypertension. How does the chest X-ray help in the etiology of the group 3 PAH?
If the parenchymal changes that we see, or if you have a hyperinflated lungs, if you have a centrilobular emphysema, if you have bullous lungs, these are seen more in obstructive lung diseases, or if you have UIP pattern or NSIP pattern that we see in interstitial lung diseases, or you could have lung cysts interspersed with normal lung that we see in LAM, that is Lymphangioleiomyomatosis, or if you have seen bizarre cysts with nodules that we see in Langerhans and histiocytosis, then these are more common with pulmonary hypertension. However, you could have a normal chest in patients who have obstructive sleep apnea or obesity hypoventilation syndromes. Or there could be thoracic cage abnormalities like severe kyphoscoliosis, which results in chronic alveolar hypoventilation, resulting in pulmonary hypertension.
That means a normal chest X-ray does not exclude pulmonary hypertension.
Sure.
The degree of pulmonary hypertension also does not correlate to the radiological abnormalities.
Yes, there is very poor correlation.
What about the pulmonary function test in the arterial blood gas? Because it was seen that even in patients with pulmonary arterial hypertension, more than half of the patient had a decrease in the FEV1 as well as the FVC. There was also, the DLCO was also decreased. Coming to the ABG, there was evidence of alveolar hyperventilation. That was the PaO2 was normal or reduced, and the PaCO2 was also decreased. So with these changes in an idiopathic PAH, how will you distinguish whether it is a case of IPAH or a patient of COPD with PAH?
COPD patients, if you look at the arterial blood gases, they are usually CO2 retainers. They retain carbon dioxide. So they have type 2 respiratory failure. So if you have a patient who has a mild to moderate obstructive disease with severe hypoxemia, hypocarbia, and very low DLCO, in this subset of COPD patients, we have to rule out associated pulmonary arterial hypertension.
The echo is the key screening tool for the diagnosis of pulmonary hypertension. It helps in estimating the pulmonary artery pressure. It also helps in assessing the RV size and function, the RA size, LV function, and other intracardiac shunt. Echo is useful in detecting the preclinical stages, the etiology, prognosis, and also in monitoring the treatment efficacy. The echo findings in PAH include RV hypertrophy dilatation, RA dilatation, RVOT dilatation. There is bulging of the IV septum to the LV, resulting in an LV eccentric index more than 1. There is functional TR, that is a high velocity TR jet, and a mid-systolic notching on the PA Doppler flow velocity. The most common Doppler indices for PAH on echo are calculation of the pulmonary artery systolic pressure, which is calculated from the maximum TR jet velocity. You can also calculate the mean PA pressure from the VTI of the tricuspid regurgitation jet or from the PR jet velocity. A diastolic pulmonary artery pressure can also be calculated from the PR jet velocity. On echo, PAH is graded as mild, moderate, severe depending upon either the mean pulmonary artery pressure or the PA systolic pressure. 25 to 40 of mean is taken as mild, 41 to 55 is taken as moderate, and more than 55 is taken as severe. When it comes to the systolic pressure, 30 to 50 is taken as mild, 50 to 70 is moderate, and more than 70 is taken as severe. However, Doppler is not without limitations, especially getting an adequate tricuspid jet is difficult, especially in a patient of COPD. Secondly, TR jet is also age and weight dependent as well as it is flow dependent. So the other indices that have been suggested is calculation of the pulmonary vascular resistance, because this calculation of PVR helps to distinguish pulmonary hypertension due to increased pulmonary blood flow from that due to elevated PR. Pulmonary vascular resistance has an important role, especially in distinguishing worsening PAH in the presence of RV dysfunction, when the mean pulmonary artery pressure remains normal or shows only a mild decrease. Other than this, the other indices include calculation of the pulmonary capillary wedge pressure, assessment of the LA size, as a dilated LA size suggests the left heart causes to be responsible for pulmonary hypertension. Assessment of RV systolic function has a major role to decide regarding the management strategies in case of pulmonary hypertension. This could be either by TAPSE or the TI index or by the 3D echo or by the tissue Doppler. The ESC guidelines for diagnosis of pulmonary hypertension says that PH is unlikely if the TR velocity is less than 2.8 and no additional echo signs of PH. PH is possible if the TR velocity is less than 2.8 or SPAP is less than 36, but with other signs of PAH. However, even in the absence of echo signs, if the TR velocity is between 2.9 to 3.4 or the SPAP is between 37 to 50, PH is possible. If the TR velocity is more than 3.4 and the SPAP is more than 50 mm of Hg, PH is more likely. Even in case of COPD, echo is the initial modality for non-invasive diagnosis. However, because of the hyperinflation optimal visualization of the heart is not possible. In fact, a study showed that estimation of the systolic pulmonary artery pressure was possible only in 38% of the patient. Another Doppler modality has been suggested by Matsuyama et al. It was seen that the ratio of diastolic flow velocity to the systolic flow velocity of the jugular vein. This showed a significant correlation with the mean pulmonary artery patient in case of COPD. A recent prospective trial assessed the correlation between the transthoracic echo and the RHC correlation of PAH severity, and it showed that there was a significant correlation between the two. A single parameter such as the systolic pulmonary artery pressure or the lateral apical RV longitudinal strain or the ratio of transmitral Doppler early filling velocity was good enough to predict the final pulmonary hypertension diagnosis in this cohort. This study also showed that transthoracic echo was 100% specific in diagnosing a precapillary PH. However, this was not confirmed, or this was contradicted in another trial, that was a REVEAL trial, a study by Farber et al., which showed that there is not much correlation between the echo and the cath. So what do you think is the role of overnight oximetry and polysomnography in the diagnosis of PAH?
In those patients who desaturate during sleep, especially during REM sleep, there could be a fall in oxygen saturation by more than 20 millimeters. So the pulmonary artery pressure will rise in such situations. So to pick up those patients who desaturate during sleep, overnight pulse oximetry could be a good screening tool. But however, if you want to pick up obstructive sleep apnea or hypopnea syndromes, polysomnography is mandatory.
So oximetry is only a screening test.
Yes.
But the gold standard is polysomnography, which we have to do.
Yes.
Okay. What about the role of a ventilation perfusion lung scan?
Now that we have a CT scan that's routinely available, it's our experience that contrast enhanced CT chest is more preferred these days and more informative to pick up obstruction in the pulmonary circulation and to pick up lung lesions. So we would prefer contrast enhanced CT chest in the evaluation of pulmonary hypertension more than a VQ ventilation perfusion lung scan.
If a ventilation perfusion lung scan is done in a case of PAH, usually it's normal, or it can sometimes show small peripheral unmatched and non-segmental defects in perfusion. What is the role of CT chest, either be it a HRCT or a CECT, in the diagnosis of pulmonary hypertension?
HRCT is to pick up lung parenchymal diseases. Say, for example, again, as we discussed in chest X-ray, this will tell us about presence of bullous lung, centrilobular emphysema, hyperinflated lungs, interstitial thickening like UIP pattern or NSIP pattern, or a combination of interstitial fibrosis and emphysema, or you could have symmetric mediastinal adenopathy with interstitial thickening suggesting sarcoidosis, or you could pick up multiple lung cysts interspersed with normal lung in a young female. It's almost diagnostic of lymphangioleiomyomatosis, or you could have bizarre cysts and bizarre nodules in a young smoker. It suggests almost diagnostic of Langerhans histiocytosis. And if you have a contrast CT, then if there are any filling defects in the pulmonary circulation, then you are almost diagnosing thromboembolic pulmonary hypertension.
So if a CT is done in a suspected case of pulmonary hypertension, or if it is done in patients who have been examined for other unrelated indications, presence of PAH is suggested by the presence of either a PA enlargement or an RV enlargement. The parameters which they take is a PA diameter more than 29 or a pulmonary to ascending aorta diameter more than 1. A segmental artery to bronchus ratio more than 1:1 in 3 or 4 lobes have been shown to have high specificity for the presence of pulmonary hypertension. Traditionally, pulmonary angiography is for the workup of CTE-PH, especially to identify those patients who will benefit from pulmonary ENVAC treatment. Contrast CT of the PA is similar or even higher accuracy for both diagnosis and is less invasive. We have the data from the NEMS radiology department, which has shown that every month nearly 100 CT scans are being done. In them, 30 CTPA scans are being done for suspected PTE cases. We have a sub-analysis of thesis presented by Dr. Rohit, our student, who has analyzed the patients of CTPA with PAH and has studied how the different parameters by CT scan correlate clinically. These were the CT parameters which were taken, that is the RV diameter, the MPA, LPA and RPA diameters. And this study showed that the MPA by abdominal aorta ratio more than 1 correlated positively with mortality, morbidity and RV dysfunction. And RV by LV ratio more than 1 on CT scan correlated with RV dysfunction on echo with a P value of less than 0.001. Septal flattening showed significant positive correlation with mortality, morbidity, and RV dysfunction. A significant septal flattening was associated with adverse clinical outcomes, the number of days in ICCU, and RV dysfunction. The increased rate of reflux into the IVC and hepatic veins was associated with mortality, morbidity, and RV dysfunction. Increased rate of reflux into the contralateral brachiocephalic vein, superior vena cava or IGV was also associated with adverse clinical outcomes, number of days in ICCU, and the RV dysfunction. Of the CT parameters that were identified as predictors of RV dysfunction, contralateral brachiocephalic vein reflex or SVC reflex or IGV reflex was 100% specific for RV dysfunction. It was also 100% specific as a predictor for prolonged ICCU stay, that is more than 7 days stays, that is increased morbidity. However, it was only around 90% specific as a predictor for adverse clinical outcome. As a predictor of adverse clinical outcome, IVC reflex and IV septal changes were most sensitive, around 90 to 95%. Coming to the role of cardiac MRI, this gives an accurate assessment of the RV size, morphology and function, which plays an important role in identifying the management strategies for patients with PAH. It is also useful for non-invasive assessment of blood flow and the RV mass. Cardiac MRI is required when a suspected congenital heart disease, especially if the echo is non-conclusive, in patients with suspected CTE-PH, and in pregnant women or patients with a contraindication to the contrast. Presence of late gadolinium enhancement, reduced pulmonary arterial distensibility, and retrograde flow have high predictability for the identification of pulmonary hypertension. Coming to the blood test and immunology, these are not required for the diagnosis of PAH, but they help in identifying the etiology for PAH. A routine biochemistry, hematology, and thyroid function test should be done in all cases. A thyroid function test should be done especially when there is an abrupt deterioration in the clinical picture. A liver function test to screen for cirrhosis or portopulmonary hypertension. A ANS screening, RF screening or ANCF to screen for pulmonary arterial hypertension due to connective tissue disorder. Thrombophilia screening for CTE-PH, that is the antiphospholipid antibodies, anticardiolipid antibodies, and lupus anticoagulants. And finally, the anti-proBNP, which is supposed to be an independent risk predictor in case of PAH. Do you suggest any other lab investigations to be done?
CPK levels to look for polymyositis, and for sarcoidosis we do ESR, C-reactive proteins, ACE levels, and MAN2 test, which is usually positive in active sarcoidosis, and which is usually it is usually negative in active sarcoidosis, and whole body PET scan to look for extrathoracic sarcoidosis and also to look for cardiac sarcoidosis is more useful in these patients.
It was of interest to note that pulmonary hypertension in case of sarcoidosis is seen as an early complications in the disease course, not in the late stages when all lymphadenopathy or fibrosis has developed.
Yes.
Hence, It is essential to identify the presence of sarcoidosis in the early stages. And it is also seen that there is no correlation between the severity of PAH and the grade of lung fibrosis in case of sarcoidosis.
Lymphangioleiomyomatosis is a multisystem disease which mainly affects young women, and this is characterized by abnormal smooth muscle deposition along the lymphatics of the thorax and abdomen. And as a result, there is formation of lung cysts, which are fairly uniform, interspersed with normal lung and abdominal tumors, predominantly renal angiomyolipomas. And these are the patients who have out of proportion pulmonary arterial hypertension. So, if you have lung cysts in a young woman with out of proportion pulmonary hypertension, think of lymphangioleiomyomatosis.
And a CT scan is usually sufficient to diagnose the condition.
Yes. You could have in addition to lung cysts, you could also have chylothorax also in these patients.
An abdominal ultrasound is recommended to identify some other clinical entities such as portal hypertension. However, portal hypertension is more reliably confirmed or excluded the measurement of the gradient between the free and occluded hepatic vein pressure at the time of right heart cath. Exercise testing is recommended during the diagnostic evaluation of pulmonary hypertension as a screening for alternative causes of patient symptoms to detect exercise injury at an intermediate stage between the normal and the resting. The right heart catheterization is the gold standard for the diagnosis of pulmonary hypertension. It is to confirm the diagnosis, ascertain the etiology, determine the severity and prognosis, and to assess vasoreactivity. Despite being the gold standard, the reference study showed that not all patients of PAH received RHC as part of the diagnostic process. The reasons could be the lack of knowledge or training, cost, or the perception of risk. Definitely, right heart cath is a technically demanding procedure and is associated with low mortality and morbidity if done meticulously at an expertise center. The interpretation of the invasive hemodynamics should be in the context of the clinical situation and the imaging. Cardiac cath should be performed only after completion of other investigations so that you are able to answer the questions arising from the other investigations, and at the same time we can avoid an unnecessary procedure if an alternative diagnosis has been suggested. The hemodynamic assessment in right heart cath includes the measurement of cardiac output, the mixed venous oxygen saturation, PA pressures, wedge pressures, right atrial and the right venous pressures. Parameters calculated from these include the transpulmonary pressure gradient, the diastolic pressure gradient, PVR, and the cardiac index. The pulmonary artery wedge pressure, a surrogate of LA pressure, should be recorded as a mean of 3 pressures. All measurements should be determined at the end of normal expiration. A minimum oximetry run from the high SVC, IVC, PA, and the systemic vessel should be taken. If the pulmonary arterial oxygen saturation is more than 75% or a left to right shunt is suspected, a stepwise assessment of oxygen saturation should be performed in every patient. On right heart cath, PAH is diagnosed by mean pulmonary artery pressure more than or equal to 25 mm of H at rest, or with a normal pulmonary artery vascular pressure less than 15, with an increased pulmonary vascular resistance more than 3 Wood units. Right heart cath showing an elevated pulmonary artery wedge pressure suggests a post-capillary pressure that is PAH due to left heart disease. In this, calculation of the diastolic pressure gradient is essential because if it is less, it shows an isolated post-capillary pH, and if it is more than 7, it includes a pre-capillary component also. On right heart cath, a mild pH is a mean pulmonary pressure between 25 to 34, a moderate is between 35 to 44, and severe is a mean pulmonary pressure of more than 45. Right heart cath is essential to distinguish patients with PH due to left heart disease. As already we have mentioned, a mean pulmonary capillary pressure is more than 15. However, mean pulmonary capillary pressure is not the criterion. It should always be supplemented with direct measurement of the LV and diastolic pressure in all patients where the wedge pressure is elevated. In some patients with a left heart disease, the wedge pressure may be reduced to 15 as the patient may be on diuretic. Then a role of acute volume challenger for around 500 ml of fluid on the left heart appears to be safe and may discriminate patients with PAH from those with LV diastolic dysfunction. However, differentiation from PAH due to heart failure with preserved ejection fraction is difficult as these patients have a normal pulmonary artery wedge pressure. So the diagnostic algorithm of pulmonary arterial hypertension includes a screening echo in all patients with symptoms and signs and history suggestive of PAH, and the confirmatory diagnosis is by a right heart cath. Right heart cath also has a role in the pulmonary vasoreactivity. This is to identify patients who are suitable for high-dose calcium channel blocker treatment. However, this is recommended only for patients with idiopathic PAH, high reactive pre-PAH, or drug-induced PAH. In all other forms, it is not recommended and may yield wrong results. Even in idiopathic PAH, only 10% of the patients show pulmonary vasoreactivity testing. The agent recommended is inhaled nitric oxide, IV ibuprostanol, adenosine, or inhaled ibuprost are alternatives. However, the use of oxygen or phosphodiesterase inhibitors or any other vasodilator is not recommended. A positive acute response on pulmonary vasoreactive testing is a reduction of the mean PAH, mean pulmonary artery pressure of more than or equal to 10 mm, or an absolute value of mean pulmonary artery pressure less than or equal to 40 with an increased or unchanged cardiac output. This is the CAT data from our institute. In the last year, a total number of PAH patients were 540, of which CAT was done in 192 patients, of which the most common etiology was the left heart disease. It was seen that all patients of idiopathic PAH had severe PAH, whereas pulmonary and CTEPA patients had moderate PAH. The severity of PAH in left heart disease varied from 51% with mild, 33% with moderate, and 15% with severe PAH. Coming to right heart cath in COPD, the indications for right heart cath in advanced lung disease is a proper diagnosis or exclusion of PH in candidates who are eligible for surgical treatment, that is either a transplant or a lung volume reduction surgery. In patients who have suspected PAH or CTEPH, patient of COPD who present with episodes of RV failure, and in patients who have inconclusive echo findings, especially if there is a high level of suspicion and potentially therapeutic implication. Recently, the German consensus group attempted severe PAH in patients with chronic lung disease, and they proposed the fact that out of proportion PAH is known when at least 2 out of the 3 criteria is met. A mean pulmonary artery pressure more than 35, or a mean pulmonary artery more than 25 with limited cardiac index, or a PVR more than 480 dynes. In such patients, right heart cath would be mandatory to come to the conclusion. So what is this severe disproportionate pulmonary hypertension?
The pulmonary hypertension is severe and the obstructive airways disease is mild to moderate, and such patients with severe PAH in the setting of in COPD patients who have mild to moderate airway obstruction with very severe hypoxemia, hypocapnia, and very low diffusing capacity. And in such patients, we say this is a disproportionate pulmonary hypertension in COPD patients. These are a minority patients. However, if we have a disproportionate pulmonary hypertension among COPD patients, we have to rule out other causes that cause pulmonary hypertension like left heart disease, obstructive sleep apnea, or thromboembolism. So the classification hemodynamic wise, we have COPD patients without pulmonary hypertension if the mean pulmonary pressure is less than 25 millimeters of mercury. COPD with mild pulmonary hypertension if the mean pulmonary artery pressure is more than 25 millimeters of mercury, and COPD with severe PH if the mean pulmonary artery pressure is more than 35 millimeters of mercury. Polycythemia has a bearing on pulmonary hypertension because of increased viscosity, and not only that, the increased hemoglobin reduces nitric oxide levels in the pulmonary circulation, so the vasoconstrictor response is much more in these patients. So pulmonary hypertension is more in among COPD patients with polycythemia.
Actually, polycythemia has a major role when we attempt to do a right heart cath in a patient of advanced lung disease with PAH. It is shown in animal models that presence of polycythemia itself can increase the pulmonary vascular resistance. This was shown in the dog models, but however, such studies in the humans have still to be investigated. But this issue should be kept in mind because there is a chance of getting a falsely elevated pulmonary vascular resistance when the right heart cath is done in the case of PAH in COPD. What is the significance of pulmonary hypertension in COPD?
Pulmonary hypertension in COPD adversely affects the survival. That is, they are associated with increased mortality. There is reduced exercise capacity and is associated with increased risk of acute exacerbations of COPD. With these patients, when they were followed up for 5 years, the survival was less in those patients who had pulmonary arterial hypertension. So, about 25% of those patients who did not have pulmonary hypertension in the beginning of the study developed pulmonary hypertension over a period of 6 years follow-up. So, and those patients who had exercise-related pulmonary hypertension among COPD patients, the development of pulmonary hypertension was twice as many patients. So, the average change in mean pulmonary arterial pressure was 0.4 millimeters mercury per year.
Coming to the treatment strategies in case of pulmonary hypertension in COPD. The goal of treatment is to improve survival, to improve the exercise tolerance, to reduce the exacerbations, and improve the quality of life. The first step is an appropriate management of their obstructive lung disease. That can be in the form of either
the smoking cessation is very important, and long-term oxygen therapy, that is domiciliary oxygen therapy in those patients who are hypoxemic, bronchodilators, inhaled steroids to reduce inflammation, vaccinations to prevent recurrent acute exacerbations, and of course pulmonary rehabilitation.
So the approach for the patient of PAH in COPD should be to counteract the hyperinflation by the use of bronchodilators, oxygen, sildenafil, or lung volume reduction surgery, to counteract the pulmonary vasoconstriction, to counteract the vascular remodeling, and to counteract the polycythemia. What do you think is the present role of long-term oxygen therapy?
Based on the two landmark studies, that is nocturnal oxygen therapy trial and a medical research council trial done about 30-35 years back, we have robust data to suggest that long-term oxygen therapy goes a long way in reducing the mortality in these patients, and definitely in those patients who have, say, PaO2 of less than 55 millimeters of mercury, or those patients who have 55 to 59 millimeters of mercury PaO2 with polycythemia or carpulmonal, these are the patients who benefited the most.
So it is not recommended for all patients, and it is useful only when there is resting hypoxemia.
Resting hypoxemia in these patients, or hypoxemia with polycythemia or carpulmonal.
What do you think is the role of the pulmonary vasodilators in the treatment of PH?
There are many studies that looked into the use of vasodilators in COPD patients, IPF patients. The two drugs that were mostly tried was sildenafil and bosentan, and we have some data to suggest that this sildenafil in COPD patients, in mild COPDs, it doesn't help much, but in severe PAH patients, in COPD patients, it may be helpful initially, but we still have to wait for long-term results. So as of now, there is still lack of evidence for long-term beneficial effect of sildenafil in COPD patients.
So especially COPD, in the absence of severe PAH, there is no evidence of long-term beneficial effect of sildenafil. However, the impact of this agent in severe PAH and COPD has been shown in some case series, but it needs to be investigated further.
Especially if you're dealing with disproportionate pulmonary hypertension in COPD patients, pulmonary vasodilators may have a role, definitely.
What do you say about the endothelin antagonist, especially the bosentan?
Yeah, there are two trials that are done, and in mild PH, again, bosentan is not found to be useful, but however, in patients with severe PH, in COPD patients, there was some beneficial effect. Again, there is still no robust data for effect of bosentan on pulmonary hemodynamics and exercise tolerance in pulmonary hypertension in COPD patients.
What about the prostacyclin analogs?
Inhalation prostacyclins was tried in a couple of patients, and it was found to be useful in those patients with severe PH in COPD patients. Again, the role of inhaled pulmonary hypertension specific therapies in COPD-related pulmonary hypertension clearly needs further exploration.
Actually, some trials have shown that inhaled iloprost was quite useful in patients of COPD as it improved the ventilation perfusion mismatch. However, the problem with inhaled iloprost was the effect lasts only for 2 hours.
Short term.
So
Yes.
they tried to investigate the long-acting prostaglandins, that is a treprostinil. However, though this is available at present, unfortunately there are no trials investigating this agent in case of PAH in COPD. What about any investigational agents being tried for this aspect of pulmonary hypertension?
Platelet-derived growth factor inhibitors like dasatinib therapy is being tried. This is a tyrosine kinase inhibitor. However, it is tried in animal studies, not tried in humans. So we have to wait and see. It sounds to be very useful.
Encouraging. Lastly, what is the role of lung volume reduction surgeries and the role of lung transplantation for pulmonary hypertension in COPD?
Lung volume reduction, especially among COPD patients, goes a long way in reducing the pressure on the capillaries so that the capillary recruitment or distensibility is much more reduced so that the pulmonary hypertension is reduced with lung volume reduction surgery and lung transplantation in patients with idiopathic pulmonary arterial hypertension or patients with COPD or patients who have lymphangioleiomyomatosis or patient with sarcoidosis has shown to reduce pulmonary hypertension.
I think there was recently a trial where a study where they had used the PAH therapy for this non-Ruffin PH.
Yes, this was a study from various centers in USA when they looked at the use of pulmonary vasodilators in non-group 1 pulmonary hypertension patients. When it came to group 3 patients, those patients who had severe pulmonary hypertension with concomitant severe parenchymal lung disease and RV dysfunction, these are the patients more likely to have received pulmonary vasodilators. However, these are all small experiences in various centers.
In fact, this study has concluded that pulmonary vascular disease treatment should use PAH therapy for patients with WHO group 2 to 5, mostly relying on the hemodynamics and assessment of RV function. That means they should use the RV function assessment to identify candidates who would benefit from the PAH specific therapy. However, as of today, the European guidelines regard that out of proportion PAH recommend the performance of transthoracic echo for screening of out of proportion PH and right heart cath for a definite diagnosis of pulmonary hypertension due to lung disease. Again, the European guidelines are against the use of pulmonary arterial hypertension specific therapeutic agent in the group 3 of pulmonary hypertension. Additionally, the optimal treatment of the underlying lung disease and the use of supplemental oxygen are the recommended therapeutic measures in such patients. An approach to the treatment of patients of PH in COPD has been suggested. The patients were divided into 4 groups. Group 1 is patients with a milder form of COPD with only mild impairment of lung functions and no gross parenchymal or airways abnormalities, but clinically relevant PH. These patients should be investigated to see whether the PAH is group 1 with concomitant lung disease or group 3 PAH due to lung disease. The second group includes severe COPD with FEV1 less than 60%. In them, presence of severe PAH, that is a mean pulmonary artery pressure more than 25 but less than 35. No data currently support the therapy with PAH approved drugs. The group 3 a patient with severe PAH in COPD, that is a mean pulmonary artery pressure more than equal to 35. These patients have a poor prognosis and may have a low normal cardiac output. It is seen that PAH approved drugs may be considered, but with thorough monitoring of the gas exchanges, that is the PaO2 and PoCO2. The last is the group 4. This is the patients with the end-stage obstructive lung disease. Unfortunately, none of the trials have included this group because of limited life expectancy. However, in the wake of the use of extracorporeal membrane oxygenation as a bridge to transplant. Now, further trials need to be conducted where they include these group 4 patients and see whether the PAH drugs are beneficial as a bridge before the patient go for transplant. To conclude, the prevalence of pulmonary hypertension in parenchymal lung disease is common and resultant complication of cor pulmonale. The pathophysiology of pulmonary hypertension in parenchymal lung disease involves an interaction between hypoxic vasoconstriction, vascular inflammation, and a loss of capillaries in the deceased lung. PH treatment is controversial for patients with parenchymal lung disease. The PH-specific therapy is an attractive option in subsets of patients who seem to have pulmonary hypertension out of proportion to their pulmonary parenchymal disease. Further clinical trials are required to determine the safety, efficacy, and appropriate patient selection for PH-specific treatments in this broad population. Do you want to give our audience any take-home?
There are a group of patients who have COPD and obstructive sleep apnea. We call them as overlap syndrome. In such patients, definitely CPAP therapy is found to be very useful in reducing pulmonary hypertension. So if you have a COPD patient with obstructive sleep apnea, these are the patients who have more severe pulmonary hypertension. So these are the patients who will definitely benefit with CPAP therapy.
Before we go to the last slide of the session, we would like to hear any questions from the audience.
Do you think that this webinar, which is interrupted in between, can we hear from any other area for having a continuity?
First of all, we are sorry for the interruption in the transmission, and those who have missed this webinar or who has not been able to see the webinar, they can see the recorded version of the webinar on the WINCARS website. And this is to inform that this is the second in the series of the PAH webinar, and the next and the last series in the PAH webinar is on management issues in pulmonary hypertension, with emphasis on connective tissue disorder and pulmonary hypertension by Dr. Bharati and Dr. Varaprasad on 31st of May. So all requests are requested to register for the forthcoming webinar at the same same. And to end the session, we take on with the take-home message for the treatment of COPD in PAH. The treatment is basically focused on the treatment of the underlying obstructive disease and the correction of hypoxemia. PH out of proportion in COPD only, the PH-specific therapy may be tried. The role of sildenafil, bosentan, prostaglandin analogs are all still to be investigated. The efficacy and safety of these in these patients is unproven. Hence, further trials need to be done where this subset of patients have to be included in the trials, and the efficacy of these pulmonary artery therapy, specific therapy, should be done. Lung transplantation is an alternative mode for these patients with pulmonary arterial hypertension.
Another modality of treatment of pulmonary hypertension. It may not be curative, but it's another way of treating pulmonary hypertension.
Thank you for joining us on this webinar on PAH.